Hello, everyone. I am Stephen Allerhand, Assistant Professor of Emergency Medicine at the Rutgers, New Jersey Medical School. In this lecture, we'll discuss some advanced topics in thoracic point-of-care ultrasound. The lecture will describe the importance of lung ultrasonography for these applications shown, illustrate the techniques, depict examples of normal and abnormal findings, offer pearls and pitfalls in making these diagnoses, and ultimately provide supporting evidence. Let's start with pulmonary contusion. Why is this lung ultrasound application important? Let's consider the following case. A 65-year-old female presents with body pains after a motor vehicle accident. Vital signs are notable for a 94% O2 saturation on room air, but are otherwise normal. ECG, labs, and chest x-ray are unremarkable, and the patient is discharged. Unfortunately, she ends up returning later that same evening with increased work of breathing, along with mild tachypnea and O2 saturation 88% on room air. It seems that she developed delayed symptoms from a pulmonary contusion. The clinical benefit of lung ultrasonography for detecting potential pulmonary contusions is highlighted by this case. To begin with, chest x-ray findings may take several hours to appear and be missed on initial assessment. The consolidation does not reach its maximal point until 24 to 48 hours after the event. On the other hand, lung ultrasonography is more sensitive and allows earlier detection of pulmonary contusion. This is especially significant for asymptomatic patients whose comorbidities, such as congestive heart failure or chronic obstructive pulmonary disease, put them at risk for delayed respiratory symptoms. Uncovering sonographic findings of pulmonary contusion may also help avoid an improper discharge or disposition to the inappropriate service. For instance, an elderly trauma patient with congestive heart failure who suffers orthopedic injuries and is found to have pulmonary contusions may be considered for the trauma or medicine service over the first 28 to 48 hours of admission. Either the curvilinear or linear transducer may be used to evaluate for pulmonary contusion. The former allows for a broader sonographic window, whereas the latter provides better resolution at the pleural line. The bilateral anterior lung fields may be evaluated first with the transducer placed in the sagittal plane. However, contracute contusions may also occur, so a more thorough evaluation would warrant assessment of the posterior lung fields as well. Here is an image of the normal sonographic anatomy of the visceral parietal pleura interface. The two ribs on either side of the intercostal space appear as hyperechoic lines with a posterior acoustic shadow, as the bone's high acoustic impedance reflects most of the sound waves. The closely opposed visceral and parietal pleura cannot be differentiated. Instead, they appear as a single hyperechoic horizontal line deep to the intercostal muscles. The white line drawn in here helps depict what is often called the bat sign. In the absence of consolidation, what is visualized deep to the pleural line is not actually the lung parenchyma itself. Instead, reflections of the pleural line called A-lines are seen reverberating to the bottom of the screen in equidistant intervals. There are two sonographic findings in pulmonary contusion. First, an alveolar interstitial focal B pattern can be found in mild cases. B lines are an indicator of increased density or fluid, and a B pattern is suggested by 3 or more B lines within a given lung field. They are defined as vertical hyperechoic common tail reverberation artifacts that arise from the pleural line, erase A lines, move with respiration, and extend to the bottom of the sonographic window without fading. They appear due to multiple reflections of sound waves that are trapped between air and water-rich structures of pulmonary tissue interstitium. With increasing severity, more B lines will appear and coalesce into larger lung rockets. The second sonographic finding of pulmonary contusion appears in more severe cases, that being a subpleural consolidation. One potential pitfall in making the diagnosis of pulmonary contusion lies in confusing B lines for Z lines. Unlike B lines, Z lines have no pathologic meaning. They may extend from the pleural line, but typically fade at approximately 2 centimeters deep. They do not clearly move with lung sliding. They are usually less hyperechoic than the pleural line, and they do not erase A lines. The Z lines appear because the closely opposed parietal and visceral pleura trap the emitted sound waves, which then travel repeatedly back and forth between the two surfaces. Let's examine the evidence. Soldati et al. Investigated the clinical applicability of ultrasound for the diagnosis of lung contusion in the emergency department, in comparison to chest radiographs and computed tomography. 121 patients with blunt chest trauma were enrolled. The diagnosis was established in 37 patients by CT scan. For alveolar interstitial syndrome and subpleural consolidation, you can see here the sensitivity, specificity, positive and negative predictive values, and accuracy in the ED. In comparison, chest radiography had a specificity of 100%, but sensitivity of only 27% in the ED. Having discussed pulmonary contusion, let's move on to physiologic atelectasis. Why is this lung ultrasound application important? Let's consider the following two cases. In case 1, a morbidly obese 57-year-old male is brought in by EMS after intubation in the field due to respiratory distress from suspected acute pulmonary edema. Despite mechanical ventilation at FiO2 100%, the patient's O2 sat remains in the mid-80s. Plateau pressures at standard tidal volumes are elevated, carrying the risk of barotrauma. The team has concern for right mainstem intubation, but they do not want to risk pulling the ET tube out given the patient's difficult airway features. The X-ray technician has not arrived to take the portable radiograph. In case 2, an 86-year-old male with a past medical history of debilitating stroke is brought in by EMS due to hypoxia at the nursing home despite attempted suctioning through the tracheostomy tubing. Vital signs are notable for an 83% O2 saturation and 100% FiO2, but are otherwise normal. Once again, the X-ray technician has not arrived to take the portable radiograph. In case 1, detecting the lung pulse, which will be described shortly, would allow immediate detection of a mainstem intubation. In case 2, detecting the lung pulse would arouse immediate suspicion for an obstructive foreign body or mucus plug. This is important because single lung intubation, or an obstructed bronchus, will lead to both immediate and downstream complications. For one, suboptimal ventilation and oxygenation will occur without gas exchange in the contralateral lung. Secondly, barotrauma from large tidal volumes may cause pneumothorax or unilateral pulmonary edema. Thirdly, an unnecessary thoracostomy for a presumed pneumothorax may be considered or even performed when only simple and slight retraction of the endotracheal tube would have sufficed. Furthermore, other measures used to confirm endotracheal tube position carry limitations. First, chest X-ray is not always readily available. Second, physiologic atelectasis is a delayed finding on chest radiographs because air trapped within the lung is absorbed progressively and not suddenly. Third, chest auscultation may be hindered by ambient noise, patient body habitus, and ongoing resuscitative measures. And fourth, quantitative end-tidal capnography is not well suited for detecting endobronchial placement of the endotracheal tube. Once again, either the curvilinear or linear transducer may be used to evaluate for the lung pulse. Mainstem intubation is more common on the right mainstem bronchus due to its more direct path compared to the left. For the same reason, an obstructive foreign body is also more common on the right side. Nevertheless, both anterior lung fields must be evaluated. Before showing the lung pulse, normal lung sliding here refers to the horizontal to and fro sliding movements of the visceral pleura along the directly opposed parietal pleura in synchrony with respiration. It rules out the presence of a pneumothorax. Lung sliding will be more pronounced in the inferior regions than superiorly, as the base has more vertical displacement with respiration than the apex does. In this clip, you can see a single A-line as a horizontal reverberation artifact. It occurs from the emitted sound wave reflecting back and forth between the transducer and the pleural line. That distance from the transducer to pleural line is thus the same as between the pleural line and the first A line, and then the same as equidistant intervals separating each subsequent A line that decreases in brightness as energy is lost through repeated reflections. The lung pulse refers to the subtle, rhythmic movement of the visceral pleura along the directly opposed parietal pleura with each cardiac contraction. It reflects transmission of cardiac vibrations through a motionless lung through which there is no airflow. This movement is not necessarily horizontal as with lung sliding, instead it also has a vertical component. Just as with the mainstem intubation and obstructive mucus plug in cases 1 and 2, this sonographic finding can also be recreated through voluntary apnea. As you can see in this clip, the lung pulse from the left side of the chest will appear more pronounced and with stronger oscillations than on the right, as the left side of pleura is closer in proximity to the heart. It's important to note that single lung intubation may not necessarily yield complete physiologic atelectasis if some air is still able to enter the contralateral lung. It would thus make sense that lung pulse is more likely to be unmasked with a deeper depth of endotracheal tube placement past the carina. Similarly, a foreign body that only partially obstructs the bronchus may not yield a lung pulse if some air still remains able to pass around the obstruction into the lung. Here is how lung pulse appears on M mode. The brief visceral pleural oscillations are represented by the seashore sign, whereas the motionless lung is represented by the stratosphere sign. The heart rate can even be calculated by measuring the duration of time between cardiac oscillations. By retracting the endotracheal tube slowly, as needed for the mainstem intubation in case 1, lung sliding will once again reappear. Similarly, by unplugging the tracheostomy tubing, as needed for the large mucus plug in case 2, lung sliding will once again reappear. One potential pitfall in the diagnosis is the similarity in appearance between the left-sided lung pulse that lies in close proximity to the cardiac vibrations and normal horizontal lung sliding. Let's examine the evidence. The lung pulse was first described by ultrasound pioneer Daniel Lichtenstein in the only study to date assessing its accuracy. The study consisted of 3 patient groups. Group 1 consisted of 15 patients who underwent selective right lung intubation. Lung pulse was detected in 14 of 15 of these patients. Group 2 consisted of 30 patients who underwent normal, non-selective intubation. Lung pulse was not detected in any of these patients. And Group 3 consisted of 15 healthy volunteers. In all 15 patients, lung pulse was visualized during voluntary apnea. 5 years later, a case series by Michael Blavis and James Sung illustrated the clinical utility of lung pulse for detecting endobronchial intubation and obstructing. In cases 1 and 2, breath sounds were absent or decreased on the right side for 2 trauma patients. Lung pulse was detected, and the endotracheal tube was subsequently retracted until normal lung sliding appeared. In case 3, a 10-month-old girl with Down syndrome was intubated for respiratory distress. Lung pulse was detected on the left, and suctioning of a large mucus plug led to the return of lung sliding. Lastly, let's move on to acute respiratory distress syndrome, or ARDS. Why is this lung ultrasound application important? Let's consider the following case. A 59-year-old obese male with diabetes and hypertension presents with shortness of breath and fatigue for 2 days. The portable chest x-ray here shows nonspecific bilateral hilar congestion or infiltrate, but is limited due to patient body habitus. Our differential diagnosis consists of cardiogenic pulmonary edema versus ARDS from an infectious cause. The management for these 2 conditions is, of course, vastly different. Pulmonary edema would call for withholding fluids and possibly diuresis, whereas ARDS from pneumonia would warrant intravenous fluids and antibiotics. Lung ultrasonography carries the ability to differentiate these 2 pulmonary pathologies and thus direct the appropriate early management in these critically ill patients. As before, either the curvilinear or linear transducer may be used to evaluate for the sonographic findings of ARDS. In order to evaluate the thorax for some of the sonographic findings of ARDS, each hemithorax can be divided into anterior, lateral, and posterior regions. The anterior segment is bound by the sternum, clavicle, and anterior axillary line. The lateral segment is bound by the anterior and posterior axillary lines, and the posterior segment is bound by the posterior axillary line and the vertebral column. For a complete and thorough evaluation, scan in lawnmower fashion along both the sagittal and transverse planes of the posterior, anterior, and the lateral regions. Once again, we use the bat sign as representation for the normal sonographic anatomy of the visceral parietal pleura interface. The following signs are strongly predictive of ARDS in comparison to cardiogenic pulmonary edema: a non-homogeneous B-pattern distribution, spared areas of normal parenchyma, pleural line modifications such as an irregular, coarse, or thickened pleural line, or a reduction or absence of lung sliding with unmasking of the lung pulse, and subpleural consolidations with air bronchograms. A triple scan protocol of the heart, lungs, and IVC has also been proposed to aid in the differentiation between ARDS and cardiogenic pulmonary edema. For instance, cardiogenic pulmonary edema would be suggested by a decreased cardiac contractility, a symmetric anterior thoracic B pattern, and an IVC with respiratory variation less than 50%. On the other hand, cardiac and IVC findings for ARDS will be more variable. To give one example, early sepsis may show a hyperdynamic heart and a collapsible IVC. Let's examine the evidence. Copetti et al. Performed lung ultrasonography on 58 consecutive ARDS or acute pulmonary edema patients upon ICU admission. As I alluded to already, they found that pleural line abnormalities, absence or reduction of lung sliding, spared areas, consolidations, and lung pulse were all significantly more likely to be present in ARDS patients than in those with APE. Lichtenstein et al. Performed a prospective study of 32 ARDS patients and 10 healthy volunteers. Using CT as a reference standard, they found that lung ultrasonography was more accurate than chest radiography for detecting the pleural effusion, alveolar consolidation, and alveolar interstitial syndrome findings of ARDS. Lung ultrasound was also able to quantify the extent of lung injury to different lung regions. In our third study, Sekiguchi et al. Prospectively enrolled 134 ICU patients with a PaO2-FiO2 ratio less than 300 on arterial blood gas within 6 hours of a new hypoxemic event or ICU admission. Lung ultrasound was performed within 6 hours of that ABG. They found that a left-sided pleural effusion, moderately or severely decreased left ventricular function, or large inferior vena cava were significantly more likely to be predictive of cardiogenic pulmonary edema over ARDS. Let's summarize the 3 main points from this lecture. First, lung ultrasonography allows the early detection of pulmonary contusion in otherwise asymptomatic patients who are at risk for delayed respiratory symptoms. Second, lung ultrasonography allows the immediate dynamic detection of physiologic atelectasis for mainstem intubation or bronchial obstruction via unmasking of the lung pulse. And lastly, lung ultrasonography allows differentiation between cardiogenic pulmonary edema and ARDS to direct the appropriate management. Here are the references. Thank you very much for your time and attention.